A detailed examination of the head and neck region is important because the majority of malformations and variations from normal occur in this region. Examination of the head and neck region, often abbreviated HEENT for head, eyes, ears, nose, and throat, primarily utilizes the techniques of inspection and palpation. Thorough inspection of this region also involves use of an ophthalmoscope. Other useful tools include an otoscope, a metric measuring tape that includes millimeter markings, a small mirror, and a brightly colored toy. Examination of the head. Begin by inspecting the head for shape and its size relative to the rest of the body and face. Look at it from all aspects, including the front, back, both sides, and top, in order to appreciate the entire contour. Look for any abnormal prominence, depression, or flattening of the skull. Compare the shape in diagonally opposite corners of the head for plagiocephaly, an asymmetrically shaped skull resulting from the premature closure of sutures on one side. Measure the head circumference in its largest plane above the ears and plot this value on the appropriate growth charts. Pick up the head in both hands to inspect the skull, scalp, and hair. Assess for any scalp lesions. Evaluate the hair for quantity, length, texture, color, direction of growth, position and number of hair whorls, and the anterior and the posterior hairlines. The hair should be clean to accurately assess these criteria. Use inspection and palpation to assess for the presence of soft tissue masses such as caput, succedaneum, and cephalhematoma. Palpate the major suture lines along their full length. These include the sagittal, coronal, lambdoidal, and metopic sutures. Normally, the space between the cranial bones ranges from 1 centimeter in width to slightly overlapping. Palpate for cranial bone mobility by applying gentle alternating pressure with your thumbs over the bones on either side of the sagittal suture line. These bones should move freely. Inspect the anterior fontanelle for bulging or sunkenness with the infant in both recumbent and upright positions. Palpate the anterior and posterior fontanelles to assess tension. To monitor serial changes in size, measure the fontanelle in the transverse diameter. The normal anterior fontanelle diagonal measurement ranges from barely palpable to 4 to 5 centimeters. The posterior fontanelle should be less than 1 to 1.5 centimeters in diameter. Inspect the face by looking at it from a directly frontal view, in profile, and in a tangential plane from the top of the head. Assess the overall appearance by looking for symmetry, size, shape, and relationships of the individual components of the face, the eyes, eyebrows, nose, mouth, and cheeks. To evaluate intactness of cranial nerve 7, look for symmetry of movement, facial tone, and strength as infant cries, yawns, sucks, or opens and closes its eyes. Observe the infant at rest for tightness of eye closure and fullness and equality of nasolabial folds. If there is no spontaneous facial movement, stimulate response to a painful stimulus to induce crying, observing for equality in opening the mouth and closing the eyes. Keep the head in midline position when assessing for symmetry. Note any evidence of pain or discomfort. Examine the facial skin for forceps marks or other lesions. If forceps marks are noted, determine if the skin surface is intact and palpate for induration. Examination of the eyes. The eyes are best examined when the infant opens them spontaneously. The examiner may choose to interrupt the flow of the total physical examination by taking advantage of this opportunity at whatever point it occurs. Recognize the infant's state and, if necessary, help him or her transition to the quiet, alert state that is compatible with spontaneous eye opening. If the infant is deeply asleep, gently raising the eyelids should either arouse him enough to open his eyes or allow you to examine each eye as it is slowly moving during sleep. If the infant is in a light sleep or quiet, alert state, he may open his eyes with a simple, gentle change in position. Be careful not to change the position abruptly to startle the infant and induce crying. Dimming the lights in the exam room often induces spontaneous opening. Before touching the infant, inspect the eyes at rest for as many elements as possible. Note the shape, size, and placement of the palpebral fissures. The distance between the outer canthi can be divided into equal thirds, with one normal palpebral fissure fitting into the inner canthal distance. Note the presence of epicanthal folds, a vertical fold of skin on either side of the nose that gives the appearance of an upward slant of the outer canthi. This is a normal finding in babies of Asian descent, but may suggest trisomy 21 in other ethnic groups. Inspect the eyelashes and eyebrows for hair amount and distribution. Assess the infant's ability to spontaneously open and close both eyelids. Note eye moisture and tearing. The newborn should have enough tears to keep the eye adequately lubricated. Palpate for nasolacrimal duct obstruction with a gentle massaging motion. The lacrimal ducts may not be fully patent until 5 to 7 months of age. Inspect the sclera bilaterally for color and presence of any conjunctival hemorrhages. The sclera are normally white to bluish-white in color. Normally, sclera should not be visible above the iris when the baby has its eyes normally open. This phenomenon, if present, is known as sunsetting and may be indicative of increased intracranial pressure. Assess the size, shape, and placement of the pupil and iris bilaterally. To assess for the retinal reflex, set the ophthalmoscope at 0 and approach the infant's eyes from the side of the head to a distance of 6 inches from the eyes. Progressively dial up to higher numbers on the ophthalmoscope until focused. The reflection of the light on the retinal surface, similar to that seen in amateur flash photography, typically is a reddish color in light-skinned infants and an orange-yellow color in darker-skinned infants. Note that the absence of the retinal reflex may be a normal finding in extremely premature infants, less than 28 weeks gestation, because the cornea is normally cloudy. Alternatively, the inability to elicit a retinal reflex could indicate congenital glaucoma, congenital cataracts, or a retinal tumor. If the infant is more than 24 to 48 hours of age, assess the infant's ability to fix and follow a moving object to test cranial nerves 3, the ocular motor nerve, 4, the trochlear nerve, and 6, the abducens. The infant's eye movements while following the object up and to the right and up and to the left reflect intact ocular motor nerve functions. Avoid the temptation to speak to the infant while moving the brightly colored object to assure that the infant is responding to visual and not auditory stimuli. Eye movements down and to the right and down and to the left reflect proper functioning of the ocular motor and trochlear nerves. The ability to move the eyes laterally and medially reflects intact functioning of both ocular motor and abducens nerves. Examination of the ears. Inspect the alignment and placement of the external ear. Draw an imaginary line from the inner canthus to the outer canthus of one eye, continuing this line toward the occiput. The point of insertion of the ear should be at this line. Be sure to assess both ears. Inspect the size and shape of the pinna. Compare symmetry of the two ears. The length of the pinna should approximate the length of the arch of the eyebrow to the tip of the nose. The width of the ear should be approximately 2/3 its length. Incomplete helix formation is commonly seen in preterm infants. Positional forces such as those resulting from breech position or long-standing maternal oligohydramnios may also result in deviations in pinna shape. Inspect the integrity of the external ear. Assess for evidence of trauma, such as ecchymosis, abrasions, or lacerations that may have resulted from forceps or cesarean section delivery. Note any pits, sinuses, or skin tags in the pre-auricular area. Although universal hearing screening is becoming routine in many nurseries, it is still prudent to assess the infant's response to loud sounds. A positive response can include eye blinking, eye widening, startle reflex, leg kicks, crying, or quieting, which would indicate intact functioning of cranial nerve 8. Although an otoscopic exam is not routinely performed in the newborn period, This method can be used to assess patency of the ear canals. Stabilize the infant's head on the forehead with the heel of the non-dominant hand. Looking through the otoscope, inspect the canals. It is common for vernix and maternal blood to be present in the canals, but in the majority of infants, some portion of the tympanic membrane is usually visible. For older infants, the tympanic membrane should be visualized and middle ear landmarks noted. Examination of the nose. Inspect the external nose and nostrils for symmetry and for visible deformities such as skin lesions, fistulae, swellings, and deviations. Determine the patency first by looking for apparent obstruction from swollen mucosa, masses, or secretions. Nasal patency can be evaluated by holding a mirror or the shiny, cool metal surface of a stethoscope in front of the nares and watching for the formation of two areas of fogging. Examination of the throat and mouth. Observe the mouth and perioral region with the infant at rest and while crying. Assess for size and shape of all the components individually and as they relate to the entire mouth and face as a whole. Judge the shape, size, and thickness of the lips in their entirety, including the philtrum. Assess the mouth at its resting position, which should appear to be comfortably closed. When the infant cries or yawns, note the position and symmetry of the mouth structures, particularly the lower lip, the angle of the mandible or jaw, relative to the maxilla or cheek, and the tongue. Because crying or yawning is the neonatal equivalent to an older cooperative patient saying "ah," observe the elevation of the soft palate, cranial nerves 9 and 10, when the opportunity presents itself. Note the shape and position of the uvula. Inspect the oropharynx for any masses or lesions. Look for Epstein's pearls, which are small white masses of epithelial cells commonly found at the junction of the hard and soft palates or on the gums. Insert a gloved finger into the mouth to palpate the hard palate for the presence of any clefts. Small clefts are easily missed if this step is not performed. Insertion of a gloved finger will often stimulate a sucking reflex. Evaluation of the strength of the suck reflects intact functioning of the fifth cranial nerve. Elicit the gag reflex by advancing your finger further into the posterior oropharynx, which tests cranial nerve 12. Estimate the state of hydration from the quantity and quality of the oral secretions and the dryness of the lip and tongue surfaces. Look for excessive bubbling or drooling of secretions. Visualize all tongue margins and surfaces and the adjacent structures. Assess color and appearance and note any lesions such as those from oral thrush or candidal infection. Note the symmetry, movement, strength, and size of the tongue. The tongue should fit well into the floor of the mouth. Look for the presence of a short frenulum between the lips and the gums or under the tongue. A true tongue tie is present when an inverted V shape is formed when the infant raises its tongue upward toward the palate. Examination of the neck. Inspect the position of the head and neck, noting the appearance of the skin and the presence of any redundant skin, asymmetry, masses, or sinus tracts. The trachea should be positioned in the midline. Extend the neck side to side and front to back, palpating for masses and noting the range of motion of the cervical spine. Compare the outlines of the clavicles for symmetry. Palpate the length of the clavicles to determine the presence of masses or a grating sensation, which may indicate fracture. Note any tenderness elicited while palpating. In summary, a comprehensive and thorough examination of the head and neck region is of paramount importance. Assessment of this region gives the examiner clues to the integrity of the central nervous system, including the senses of sight and hearing. The majority of congenital malformations present themselves in this region, guiding the examiner in development of a more detailed assessment of related body systems and use of appropriate laboratory and imaging diagnostic tools.